This session, I will be talking about the hemolytic anemia. So, the Robbins says that the anemia it is defined as the reduction in the total circulating red cell mass below the lower limit. Below the lower limit. So, anemia can be due to decreased RBC production or increased RBC destruction. In hemolytic anemia, the anemia it is due to excessive destruction of RBC. Excessive destruction of RBC. So the hemolytic anemia it shares the following features. That is, it has a shorter lifespan, less than 120 days because of increased RBC destruction. So due to anemia, there is elevated erythropoietin. So erythropoietin level is increased. So there will be compensatory increase in erythropoiesis. So there is compensatory increase in erythropoiesis. Then due to hemolysis, the hemoglobin is released into the blood and is degraded. So there is accumulation of hemoglobin degradation products. So there is accumulation of hemoglobin degradation product. Normally, the RBC, normally this RBC, they're actually destroyed in the macrophages. So when the RBCs becomes old, they are destroyed by the macrophages which are abundant in the spleen, liver and bone marrow. So when the RBC becomes old, this RBC is having surface protein. So these surface protein will have certain changes, that is age dependent changes. So that is why these phagocytes, that is the macrophages, will recognize this senescent RBC or the old RBC and destroy it. We have two type of hemolysis, that is intravascular hemolysis and extravascular hemolysis. Extravascular hemolysis. As the name suggests, intravascular hemolysis, there is the destruction of RBC, within blood vessel. Whereas in extravascular hemolysis, there is the destruction of RBC outside the blood vessel, that is in the liver or spleen. So in the extravascular hemolysis, there is actually the premature destruction of RBC within the phagocytes. So within phagocyte. So this, if it is persisting, this will lead to hyperplasia of the phagocytes, and there can be splenic enlargement. So there will be splenomegaly. So in extravascular hemolysis, there will be splenomegaly. So we are having two types. That is, this is another classification. In intracorpuscular and extracorpuscular. So intracorpuscular as well as extracorpuscular. Intracorpuscular is of two types. So one is hereditary and the next one is acquired. Intracorpuscular means that is something within the RBC. For an example, in hereditary, if there is membrane defect, if there is defect in the RBC membrane, so if there is membrane defect, I will give you examples, and these each one will be discussed in detail. So the membrane defects include the hereditary spherocytosis and hereditary elliptocytosis. Hereditary spherocytosis and hereditary elliptocytosis. So in this hereditary group itself, it can be due to certain enzyme deficiency. For example, the G6PD deficiency and the hexokinase deficiency. So the third one includes the hemoglobinopathy. So hemoglobinopathies include sickle cell anemia and thalassemia. In acquired, there is paroxysmal nocturnal hemoglobinuria. So the extracorpuscular, that is due to the factors that is outside the cell. It can be immune mediated or it can be non-immune mediated. So the non-immune mediated is an example is the infection. So when there is an infection, it is an external factor that will cause, there are certain infections that will cause the hemolytic anemias. The immune mediated include the autoimmune hemolytic anemia. So the antibodies are made that is against the RBC and that will cause hemolysis. Another one is the ABO and RH incompatibility. Now the clinical presentation of the hemolytic anemia. So this is anemia, right? So there will be pallor due to decrease in hemoglobin level because RBCs are destroyed. Because of RBCs are destroyed, the hemoglobin is released into the blood. So that will get degraded and there will be jaundice because the hemoglobin degradation product such as the unconjugated bilirubin that will be increased in blood. Unconjugated bilirubin. This hemoglobin that will be converted into heme and globin. So globin, it is a protein that will be broken down into amino acid, and that will go to amino acid pool. Heme is containing iron, and so actually heme oxygenase is acting on heme, and the iron is released. The it will be converted into biliverdin and then into bilirubin. So the level of unconjugated bilirubin will be increased, and that will be manifested as jaundice. The patient can also present with splenomegaly in case of extravascular hemolysis. So, saying something about the extravascular hemolysis. So this extravascular hemolysis, it is most commonly caused by alterations, that is the changes in the RBC that make the RBC less deformable. So the changes in the RBC that makes it less deformable. So to go through the splenic sinusoid, the RBC must change its shape. So in this case, there is actually reduced deformability. There is reduced deformability. So this reduced deformability, the RBC passing through the splenic sinusoid becomes difficult, and there is the RBC, it gets sequestrated and it gets phagocytosed by the macrophages which are located in the splenic sinusoid. So while going through the splenic sinusoid, the RBC gets sequestrated. That is, some part of the RBC will get separated, and it will be phagocytosed by the macrophage which are located in the splenic sinusoid. So the main clinical features of the extravascular hemolysis are, it is hemolysis, so there will be anemia. The macrophage are phagocyting at the spleen, so there will be splenomegaly, and there will be jaundice. And one more thing is that in our plasma we are having haptoglobins. So haptoglobins are alpha 2 globulin. So this haptoglobin, it binds to free hemoglobin, and it prevent the excretion of hemoglobin through urine. So some of the hemoglobin released, it won't be it will escape the phagocytosis by the splenic macrophage, and it will go and bind to the haptoglobin. So when this free hemoglobin, it binds to the plasma haptoglobin, the level of free haptoglobin decreases. So there will be a variable decrease in the plasma haptoglobin. So as there is premature destruction, of the RBC in spleen, so the individuals with extra hemolysis, they often benefit from splenectomy. they often benefit from splenectomy if the spleen is removed. The intravascular hemolysis. The intravascular hemolysis of the RBC, it can be caused by mechanical injuries. Mechanical injuries such as the trauma which are caused by the cardiac valve or by the narrowing of the microcirculation by thrombus, or if there is a repeated physical trauma in marathon running. The intravascular hemolysis can be caused by the complement fixation. So complement fixation, it occurs in a variety of situations. When the antibodies, it go and bind the RBC antigen. Then the intravascular hemolysis can be caused by the intracellular parasite such as falciparum, malaria falciparum. This can cause hemolytic anemia intravascularly, or even certain exogenous toxic factor. So exogenous toxic factor, that is the certain toxic injury by, for example, if there is a clostridial sepsis. If there is a clostridial sepsis, certain enzymes are released and that enzymes will go and digest the RBC membrane and there is hemolysis. So in intravascular hemolysis, there is anemia. Due to hemolysis, hemoglobin is released into the blood. So there is hemoglobinemia. Hemoglobinemia. So when more hemoglobins are released, they appears in the urine and they will form hemoglobinuria. As there is more catabolism of heme, there will be jaundice. As there is iron release, there will be hemosiderin in urine, that is hemosideриnuria. So if this is an RBC and due to lysis of this RBC, the hemoglobin are released into the blood. Free hemoglobin are released into the blood. So in blood there is haptoglobin. This will bind to the free hemoglobin and they will form a complex. So this complex, it will be cleared by, so this complex, it will be cleared by mononuclear phagocyte. So it will be cleared by mononuclear phagocyte. So as the serum, after some time, the serum haptoglobin gets depleted. So there is no serum haptoglobin. But still the hemoglobin is released. So this free hemoglobin, that will be oxidized. So the free hemoglobin will be oxidized to methemoglobin. It will be oxidized to methemoglobin. So this methemoglobin, this is actually having a brown color. So the methemoglobin is having brown color. So the renal PCT. So in our kidney, there is renal PCT. So the renal PCT, it reabsorb and break down the filtered hemoglobin and methemoglobin. So they will reabsorb it and break it down. But some will passes through the urine. Some of the hemoglobin and methemoglobin will passes through the urine, and that makes the urine brown in color. So urine becomes a red brown in color due to the passage of hemoglobin and methemoglobin and methemoglobin in urine. So the hemoglobin was taken into the renal PCT. So iron is released. So this iron, it accumulate. So the iron accumulate within the renal tubular cells. Renal tubular cells, and it give rise to renal hemosiderosis. So it becomes renal hemosiderosis. So here we are having hemoglobin, then we are having the hemoglobin haptoglobin complexes. From that heme is derived, which are metabolized to bilirubin, and they are phagocytosed by the mononuclear phagocytes, and that leads to jaundice. So in intravascular hemolysis, the splenomegaly is not seen. If there is chronic hemolysis, so in clinical presentation of hemolytic anemia, if there is chronic hemolysis, there is a chance to form pigment gallstones. It is because when excessive bilirubin is excreted by the liver into the biliary tract, it leads to the formation of gallstones that is derived from the heme pigment. So this pigment gallstone, it is also called as cholelithiasis. Cholelithiasis. So when you are doing a lab test, you can see that the level of hemoglobin is reduced and the level of unconjugated bilirubin is increased, and the reticulocyte count is increased. So why there is increased reticulocyte count? So when there is hemolytic anemia, due to the hemolysis, there is anemia, right? Plus there is low tissue oxygen tension. So there is anemia and a low tissue oxygen tension. So more erythropoietin erythropoietin are produced. So it will stimulate the erythroid differentiation, and the result will be the increased number of there will be increased number of erythroid precursor, that is normoblast in marrow. So in bone marrow there will be increased number of normoblast, and there will be in the peripheral blood you can see the reticulocytosis, because more reticulocyte will be released into the blood, so there will be prominent reticulocytosis. So in the lab test there will be increased lactate dehydrogenase also. So in case of intravascular hemolysis, in the lab test you get there will be hemoglobinemia, that is increased level of hemoglobin in blood, hemoglobinuria, that will be excreted through urine, and there will be hemoglobinuria. Then there will be hemosideruria. Then there will be methemo. Then there will be decreased serum haptoglobin, because the hemoglobin will bind to the free haptoglobin and the level of free haptoglobin will be reduced. So the explanation, so the details I have explained above. So in the hemolytic anemia, the RBCs, the RBCs are phagocytosed by the macrophages. So the iron containing pigment that is a hemosiderin. So this hemosiderin, it gets accumulated in the spleen, in bone marrow, and in liver, and this will lead to hemosiderosis. So there will be hemosiderosis. So if the anemia is severe, in case of severe anemia, there extramedullary hematopoiesis happens. Extramedullary hematopoiesis. It takes place in the liver, it can happen in the spleen, it can even happen in the lymph node. So by summing up, in intravascular hemolysis, there will be hemoglobin released into the blood, and these hemoglobin will be excreted through urine. That is, there will be in intravascular hemolysis, there will be hemoglobinuria, and they will form, and the hemosiderin, it will also be excreted through urine. There will be hemosideриnuria. So when free hemoglobin are released into the blood, they binds to the serum haptoglobins, and the level of serum haptoglobin is reduced. So the level of serum haptoglobin is reduced. But the hepatosplenomegaly, that is a liver and splenic enlargement. So they will be, sometimes they will be present, sometimes they will be absent. So this hepatosplenomegaly, it is more pronounced in extravascular hemolysis because there will be hepatosplenomegaly in extravascular hemolysis, and there won't be any hemoglobinuria, there won't be any hemosideриnuria. So the decreased in the serum haptoglobin, it can be present or it can be absent in extravascular hemolysis. So in the next module onwards, we will be discussing about the pathogenesis of each type.